Hello, thank you. Thank you, everyone. We're about to kick off the event. So thank you so much for coming out today. I just wanted to start by saying thank you and introducing the track. So I've seen many familiar faces. This is actually the 5th event of the Digital Health Track. So we kicked it off last September and we've had an overwhelming attendance. I'm particularly excited about this event. It's the first one that we actually talk about policy. Most of the other events have been about technology. And so this one is really about policy, which is well needed at this point in time. And I wanted to remind everyone that we have 2 more events coming up, already defined, in a month from now on March 20th. We've got Dr. Lustig, who's an MIT alum, and he's going to be talking about the true purpose of nutrition. And then a month later, it was actually just confirmed today that we're going to have a roundtable with Sami Inkinen, who's the founder of and CEO of Virta Health, and we're going to be talking about metabolic syndrome. And it's packed. After that, we've got a women's health event in May. It's organized by our own Sophia Yan. She can't be here today. And then we're going to wrap up the year with another policy event around evolving standards of care. So stay tuned for all our events. And I want to especially thank our speakers for taking the time to come out today. And I want to thank Invent Health also for co-hosting this event with us. So if you're interested in volunteering for the track or for the club, please reach out to me or any of the other volunteers that are here. Jason, raise your hand.
We're here tonight.
Other volunteers, Romel. So reach out to us and we'll take your number. We're a very active group. We've been determined to have one event every month and we've kept to it. So thank you for coming out. Enjoy the event.
Yes, this is on?
Yes.
Hi, everyone. I'm Bambi Francisco Roizen, and it's great to be here. This is quite a turnout, so I hope we do you justice with this panel, but I'm pretty sure the panelists will do that. I'm here to just be the timekeeper and ask some questions. But just so you know, we will be talking from 6:30 to 7:30, and then for 30 minutes, you'll have time for Q&A as well. Just a little bit of background, I am the founder and CEO of Vader, which is a media company, and we also focused on startups, innovation, and venture capital. We've also done some angel investing in startups. I'm also the co-founder of Invent Health with Arshana. We started that in 2017. It's a focus on healthcare, and we hold quarterly salons around healthcare. So let me pass this on to Arshana.
So what do I do again? Introduce?
Yes.
Yeah.
Everybody introduce.
I'm going to have everyone introduce themselves.
Okay. Excellent. So I'm Archana Dubey. I'm a physician by training and have been practicing for nearly 28 years, so I'm definitely aging myself. I have practiced in the likes of UC Davis and then for almost 15 years at Stanford University, teaching, academic, and then working alongside the business side of Stanford. Following the trail of impact, I joined large employers as their corporate health strategist or corporate medical director, global medical director, CMO of companies like Google, Qualcomm, Tesla, HP, and HPE. I still am part-time chief medical officer consultant at HP. My day job today is chief medical officer for United Healthcare commercial line of business. And I'm here to talk about value-based care with my esteemed co-panelists.
Great, thank you. Can everyone hear me okay? Great. My name's Pam Lech. I'm the Senior Vice President for Clinical Services at Hill Physicians. And I don't know if all of you are familiar with Hill Physicians, but we're a large independent physician association. Here in Northern California, we have about 5,600 physicians as part of our group. We are in 14 counties, from San Mateo up through the 80 corridor, up through Sacramento, up into the foothills, and then into the Central Valley a bit, into Stockton and Stanislaus area. We have about 250,000 managed care lives in the HMO line of business, and another 125,000 or so attributed lives in the PPO business. So, just about 400,000 lives in total. A little bit about myself. I'm an emergency physician by training, and I worked and practiced in the emergency department for 10 years, mostly in Berkeley and Oakland, also a bit in Chicago and in Austin, Texas. And after that, I was a regional medical director for HealthNet, so learned a little bit about the health plan side of the business, and spent a couple years there. Then I transitioned as chief medical officer at Brown & Toland, which is actually one of Hill's competitors. And now I've been at Hill Physicians for just over 5 years. I'll pause there for a moment. I don't know if everyone's familiar with what an IPA is or what that model is like, and I'm happy to explain more as we get into the conversation more.
Thanks, Pam. I'm assuming everyone can hear me as well. Conwyn, I'm a pharmacist by training, so a little bit of a reunion and a history for me here today. Pam was my old boss. Yeah. So this is a nice reunion, and then all the hard questions go to her, and all the hard questions go to 2 practicing physicians that are sitting in the audience today that are also a part of Hill and also clinical advisors for Coziva. So a little bit of background about myself. I'm a pharmacist by training, kind of grew up in the Bay Area, only know about the Bay Area, and this job has broadened my horizons across the nation. Spent 14 years at Hill Physicians Medical Group, so very, very deep in the value-based work, very deep in physician engagement, quality performance, delivering not just the patient experience piece, but how do you start to weave in health equity and all of those emerging important domains of value-based care. So 14 years there. In 2015, I was one of the first first 3 customers, California customers of Coziva, the platform. So Coziva has been in the market as a population health tool and platform for both quality, risk adjustment, analytics. It's really the operating platform for all things value-based care. So if you think of line of business agnostic, so whether it's commercial, Medicare, Medi-Cal, the platform service all populations. Contract agnostic, health plan agnostic, EHR agnostic. So we pride ourselves in being an all agnostic platform. Anyways, 2015, I was probably the most difficult customer starting. And through that journey, about 2 years ago, made the jump and leap to the vendor side and became the CEO. So CEO of Coziva now, and like I said, we're a platform that operationalizes a lot of the concepts that we'll be talking today as it relates to value-based care. And we support the health plans, the provider groups, the IPAs, all the way down to the individual physicians and the practices and the staff. Right now, we support actively over 20 million patients across the nation, and our footprint is across 20 states.
Good evening, everyone. My name is Ed Yu. I'm a family physician by training, and actually I live in the neighborhood. I've been practicing family medicine myself down at Palo Alto Medical Foundation. Actually, my home clinic is just down the street in the Mountain View campus near 85 and El Camino. That's my clinical role. I've been practicing here for over 25 years, and I'm here kind of representing Sutter Health, one of the largest integrated healthcare systems in the United States. We take care of 1% of the population, so over 3.5 million active patients belong to us, one of the largest group in Northern California. My role over there is I'm one of several chief medical officers there. I oversee their population health services over there and focus on how to deliver wraparound services to our value-based care experience. So that's kind of what my clinical administrative role is. Also, I bring the perspective because I represent both my medical group and also Sutter Health on Integrated Healthcare Association, IHA, which is one of the largest and in multidisciplinary group that defines value-based care metrics and measurements in the state of California. We've been inaugurating members of that for over 20 some years, and I sit on a governance committee and I chair their technical measurement committee to define the standards for how we measure success and quality and also in value as well, so I can bring that perspective as well. I'm I'm also involved with policy through the California Medical Association as well. I chair their large group practice forum and kind of help kind of define and drive policy initiatives from the California Medical Association for the state of California and how we promote, among other things, value-based care from a physician perspective and all that. So I'll look forward to discussions with you, in particular the questions you may have. So with that, I'll turn it over.
Great, thank you. Hi, good evening everyone. My name is Afsana Akhtar. I am one of the co-organizers of this event. I've been a longtime contributor to the digital health track, working with the alumni organization in Northern California. So I want to thank all of you for coming out tonight, and I want to thank our panelists, many of whom drove from pretty far away. I think many of us are here to learn, and because we're motivated to make change, we're sitting in the epicenter of innovation and disruption, and I hope that we can share with you and that you leave today with the desire to make healthcare better for yourselves, your family, your community, and the system at large. A bit about my background. So I'm an alum, I'm an engineer. I was Core 6 undergrad in MEng. I worked in tech for 6 years and then serendipitously moved into healthcare. And I say that because I had a chance to meet with a number of folks who also have been in tech and are now thinking about moving into healthcare. And it's been a very rewarding journey because I get to scratch the itch of loving to solve problems. There are many problems to solve in healthcare, and then there are many ways to apply technology to solve those problems. But it's rewarding because it is having a human impact. A bit about my background. So after moving into healthcare, I've been working in the digital health field for almost 18 years, primarily in commercial roles, helping push innovation into the system with providers, payer adoption, and I've had the opportunity to work in many different areas. So I've worked in the diabetes space with a company called Livongo Health, helped move adoption there with payers. I've worked in the musculoskeletal space around pain, also taking a digital-only solution to payers and providers and Medicaid and Medicare primarily. I've worked in predictive analytics, really trying to help payers and providers look ahead to where the highest kind of critical care or risk or cost is coming from and trying to proactively avert that. And then most recently, have been doing a lot of work in mental health. Most recently, I was the CEO of Amelia Virtual Care, which is a VR platform for mental health, and helping mental health practitioners use technology to improve outcomes, improve scale, efficiency, all of those things. And I'll share one aspect. We'll all be talking about, what does value-based care mean to us, to the system? Imagine you have a family member who is ill, and they're going to see the doctor over and over again, or a counselor, a therapist, but you're not seeing improvement, but you're still paying for it. And that can be frustrating because you're wondering, well, are they getting the right kind of care? Are the best practices being utilized? How do I measure their improvement? Who's measuring their improvement? Who's holding the clinician accountable? Who's holding the system accountable? So that's one of the things that value-based care tries to address, tries to put more focus on outcomes, value, quality, and improvement, versus just the fee-for-service. Okay, I did such and such test, I'm doing such and such service, and you're paying, they're getting paid, but where's the improvement, where's the value? So that's why value-based care is important to us as consumers and patients, and that's why I think it's a really important and exciting topic for all of us.
Thank you. Well, now that you've heard a little bit from us, we want to understand who's in the audience. So how many here are entrepreneurs? About half. How many here are physicians? Okay, less than that. Oh, who are the rest of you? How many of you are patients?
Go again.
How many of you are patients frustrated with the system, and that's why you're here to understand if value-based care can fix it? Okay. All right. Well, So here's some surveys. 64% of Americans support value-based care over fee-for-service. 59% said they supported the term value-based care, but 75% associated the term with cheap, low-quality services. I'm not sure that the panelists think that that's what value-based care means. So it's interesting to see that there's this disconnect between what patients think and what the providers think and payers think, but also in a McKinsey report, it said that indeed actually all stakeholders in the health community define value-based care differently. I don't know how we can improve care if we're all not using the same definition of value-based care. So I think we should start with that. According to CMS, value-based care is a term that Medicare doctors and other healthcare professionals sometimes use to describe healthcare that is designed to focus on quality of care, provider performance, and yes, patient experience. So based on this definition, care delivery is not about just services and procedures and done, but outcomes and the experience of the patient. There are many VBC models out there, accountable care organizations, episodic-based payments, condition-based payments, capitation, like a monthly subscription. So I want to ask each panelist, what is value-based care to their specific organization? Meaning, what do you see most frequently used and what's most effective?
I would say from a perspective of somebody who has been an employer, a strategist, and then also as a health plan, and it's not specific to United Healthcare, it's kind of, I would be more general around how health plans see value-based care. And then of course, having practiced in the value-based environment at UC Davis and others, I would say that as a practitioner, value-based is looked through different lens. And most of the value-based care definitions and contracts and relationships are mostly defined between the provider and the health plans. Generally, the member is, or the patient is not part of that deal in a way. And that is kind of the disconnect. I would just say that that is a gap that we need to all address. So looking at from as an employer, typically an employee stays with an employer for more than 5 years. And so value-based care does become extremely important as a buyer of, as a commercial buyer of healthcare. So in my positions with the large employers, value-based care was defined as the member experience first, and then the cost and quality that comes as a result of member experience, engaging them, activating them, and making decisions alongside the providers so that collectively they're making informed decision and picking the right choice that is higher value, higher outcome, and optimal cost utilization. So from an employer perspective, that is the definition. From a health plan, which is a much shorter span, typically people stay on a health plan for 2 years. The value-based care definition now focuses a little bit more on the cost because the return on investment becomes a little bit more. Member experience is still very important because you want the member to stay engaged with the health plan, and then the quality. So still the three, but the weightage kind of changes in that order. So I would just say that two different perspectives.
Great, that came out kind of loud. Yeah, when we look at value-based care, probably from a physician organization, I want to think more on the quintuple aim. We talk a lot about quality and cost and patient experience, but there are actually two more components to that, and one of that is the physician experience, the provider experience, right? We also have to take into consideration that the joy of medicine, right? Obviously, everything is very outcomes-based. We want to have the best health for our patients. And the fifth one is health equity. We really need to make sure it is not one size fits all. There is that shared decision making. There are different race, ethnicities, different cultural differences, and there are definitely disparities around different types of cancer screenings, affordability of medications, access to services that we all need to take into account. So from from that aspect, I think that those are the most important aspects that we strive for. And really, we focus on outcomes. What are the patient outcomes? Ideally, we'd like early detection of disease, right? Get patients into health education, into maybe, like now, continuous glucose monitoring. You may be diagnosed with new diabetes. How do we get those patients into these programs when they're not within the four walls of a physician's office or a telehealth visit, right? Because people live most of their lives outside of that situation. So I will add over here to Con.
Thank you. So just to add to our two speakers here, value-based care, and now I'm speaking from the lens of the technology vendor, the platform. So what was described as the perspective and the importance from an employer, purchaser of healthcare, to then what is actually really important for a health plan, to what is needed to operationalize and carry out the contractual relationships from a provider organization, we are the platform that allows that to happen. So value-based care from our lens is, all of these perspectives are super important, and how do we surface actionable data, actionable insights, real-time performance reporting, so that care at the point of care is being delivered at a higher quality and more cost-effective, and layers in all the aspects of health equity, for example, in patient experience. So as a platform, we enable all of that. We help operationalize all of that. And we also do see all the crazy variations of value-based care. NorCal versus SoCal, even within the state of California, a very highly delegated ecosystem, right? So the health plan delegates the care of the member to a provider organization who then contracts with a network of physicians who actually deliver the care. In Southern California, we see like delegation after delegation after delegation, meaning it's a health plan to another health plan to another health plan to a provider organization to a provider that like is contracted with so many different players. So when we as a platform say we enable and we help operationalize and make value-based care easy for all the stakeholders, we are also thinking about it from the lens of the practicing physician. So think of that physician who's contracted with like 30 different payers, and payers can have very different meanings, right? A provider group or a health system or a health plan for direct contracting. As a physician, it is overwhelming to understand, well, for this contract, what do I have to pay attention to? And for this population, what do I have to pay attention to? Versus you want to make it simple and easy for the provider to just do the right thing. So for us is how do we, as a technology first approach, how do we help all the stakeholders achieve that? The second thing I'll mention is transparency and data. So in order for all of this to actually carry out and happen, you have to have the data, and you have to have the ability to use the data in the right way. So as a platform, we do that, and we do that on behalf of all of our users. And then we also have the ability to create transparency across provider group, health plan, all the people that are touching the same patient, all the people that are, quote unquote, having slices of care for that same patient, now get to see that information and the real-time reporting of the quality of care delivered for that patient.
So I'll answer that question in a framework about how payment is flowing in healthcare, right? Traditional ones, you pay fee for service. The more you do, the more you get paid. The sicker you are, the more surgeries you have. And in fact, if a complication that a hospital caused you that need to fix that, you get paid more for that. So it's kind of a pay for volume perspective. So in our paradigm in value-based care, you're really paying for outcome. So when I tell this story to our clinicians and our clinical teams, I tell them the mission in value-based care and the definitions you have to do really boils down to two things. One is here, your mission is to improve the health of the population that you serve. So in this paradigm, instead of waiting for that heart attack to happen, where then you put in a stent, and then put him in rehab, and put him on a gazillion medications, in a value-based care world, you want to move this upstream where your promotion here is on health. You want to see that patients who prevent them from getting diabetes. If they are inactive, get them active. If they are at risk of having high blood pressure, mitigate that so that they don't have the chronic disease burden and then escalates down the pathway where heart attacks and strokes happen and inevitably it's more expensive to take care of them. So how do you improve health? So that's where we're to focus on prevention. Screening for cancers, detecting them early. Promoting vaccines to prevent preventable communicable diseases are examples of many. So that's one, improving the health of the population that you serve. So that's on the quality part that my colleagues have mentioned. Then the other one, kind of want to reference back to kind of what you mentioned about value-based care, is not about the cheapest care. That's a common misconception over there. So the second mission on that, your job over here, and I tell my clinical teams, is to reduce avoidable cost. Not all costs are avoidable in healthcare. If you have a patient that ends up having leukemia and needs a bone marrow transplant to get the outcome, you spend the money and spend the resources to get that. And it's not always the cheapest care. Where it matters, and this is you may have heard of a lot, in healthcare, the way how we're set up, we're siloed, things are not integrated. There is tremendous waste in the system. Our job over there is to take out the waste, take out the inefficiencies in that, from medication prescriptions, using antibiotics when they're not helpful, type of diagnostic test that we need to do that informs care outcomes and treatment plans. Many, many examples of that. And going back, part of how you do make that paradigm over here is understanding where patients are, getting back to the health equity piece, getting back that each patient is different. Not all patients with back pain wants a surgery, right? How do you understand where they are, where they want to be, and match them where they are with different clinical pathways to generate the outcomes that's where you want to go. So improving health and reducing avoidable cost, that to me is what the mission of value-based care should be.
Thank you. Did you want me to answer the same question? Yeah. Okay. I'll add a couple of things here, more from the perspective of the digital health company or the entrepreneur. I think every digital health company kind of needs to figure out where they fall in this ecosystem of value-based care. Are you a tool or are you a service provider? Because if you are a service provider of some sort, whether you're tech-enabled or not tech-enabled, if you are a provider that is offering your services to a health plan or a provider or an employer, you, in the eyes of value-based care, are now accountable for some sort of outcome, quality metrics and all the various other measurement metrics for value-based care. And so that's just important to know because sort of what Khan mentioned, the criteria kind of flow down. It will flow down to the digital health vendors as well. So if a health system is using a digital health company for diabetes or musculoskeletal or hypertension, they will push some of the accountability and the responsibility to those digital health vendors or providers. But if you're a tool, like an electronic medical record or some AI tool, if you're able to show some benefit, how you benefit outcomes, how you benefit measurement, then there's a value proposition you have towards value-based care, but otherwise you kind of don't have to prove that outcome. So I think as a digital health company or a startup in healthcare, you kind of have to figure out where you fall. I also want to point, I sort of want to underscore that in healthcare, that relationship between cost and quality is very counterintuitive because in every other aspect of our life, higher quality is associated with higher price, or higher price is associated with higher quality. In healthcare, it can really be the inverse. And that's what I think consumers often don't realize. And why is that? Because when a surgery is done or a test is performed, if it's done well, it doesn't lead to complications. It doesn't cause readmissions. It doesn't lead to duplicated effort and tests. And so the cost can actually be lower when a service is higher quality. And that's something I think we as consumers need to keep in mind. So when we select providers or even a health plan, we need to look for quality, not just price. The challenge is that the words that are used to describe quality in healthcare are also not common terms. You know, how many people have heard of HEDIS or STARS? Yeah, I mean, that's how quality is described in healthcare. It's not what the average person is, it's not our dinner table language. So we have to, it's important for the healthcare system to present quality in a consumer digestible way, and it's also important for us as consumers to really ask the question, well, you know, I'm picking a provider, how do I know who's better quality, who's going to give me the best care, and not just judge it based on, oh, this one's more expensive, so it should be better, right? Not necessarily. So I'll stop there.
So now you all know what value-based care means, right? Okay, well, we're going to dig deeper into outcomes, because the panelists mentioned outcomes, as well as measuring outcomes, measuring quality. But I think the proof is also in the pudding when we look at adoption. So if it's adopted more, maybe that means it is really working. So let's talk about adoption. When I say really working, it means that we are improving healthcare, we're improving the patient's health, and we're lowering costs. So let's talk about adoption. And I want to pose this question to Ed and Pam, because they represent the physicians. According to 2019 figures, 38% of healthcare dollars flowed through VBC, a value-based component. So to each one of you, what percent, Pam and Ed, what percent of your patient population is charged or in contract with the VBC model?
I can lead that off. So to explain a little bit about what Hill Physicians is, as I said, we're an independent physician association. So we are part of that delegated model here in California where Khan alluded to, you know, you as consumers, you pay your healthcare premiums to United, and then United will capitate us to a certain percent of the premium to take care of the patients, right? So we are given our pot of money and we are using that to then deliver our care. Hill Physicians has been around. We're going to be our 40th anniversary next year, actually. So we've been at this a very long time. And we started with that delegated HMO model. And so when we look at Hill Physicians as a medical group and our attributive lives that I spoke with earlier, 100% of our patients are part of a value-based contract. Now, that being said, our physicians also do see some other fee-for-service patients. So we've got Medicare fee-for-service, for instance. They also see PPO patients. From the PPO standpoint, we have PPO accountable care organizations with 5 health plans, United being one of them, where if those patients are seeing our physicians, they are attributed to us and we treat them the same. So our physicians are using the expertise that they've gained with, you know, not all the physicians have been at it for 40 years, but 40 years of that model and applying that to that fee-for-service world and PPO to, again, really think about, yes, site of service, the preventative screening, everything like that, right? I know where Ed's gonna go with this too, probably on his side. And even for those Medicare fee-for-service patients, although they are not technically Hill patients, we also have acted as a convener for our physicians to work with another company that is part of the ACO REACH, which is another CMS ACO product, so that they can also use that expertise that they know from their experience with us and apply that to those Medicare fee-for-service patients as well. So technically, Hill's patients were 100% in value-based care. Now, what are these value-based care contracts? I had to write them all down because there's a lot of them. So we've got HMO capitation that I talked about, right? We get paid per member per month, and we earn a shared risk arrangement, which means we are responsible for the doctor's bills and lab, x-ray, physical therapy, those sorts of things. On top of that, we have shared savings with some of our health plans, And some of that is based on how we perform. For IHA, which I also sit on government with Ed, the Integrated Health Association, where we're compared against our peers and against ourselves year to year. And we can get award recognition from this, and we also get dollars from our health plans for performing well. We also have, in addition, on our HMO side, we have accountable care organizations with some health plans. So we also have to meet cost targets and quality targets and gates to be able to get payment, extra bonuses based on the quality and outcomes that we produce. If you've met one HMO ACO, you've met one HMO ACO. They are all very different, to Con's point of how do we keep it all straight. Also, we take on full risk, which is for some Medicare Advantage patients. We take on not only the financial responsibility for the professional side, but also the facility side. So now we're paying the hospital bill, the ambulatory surgery center bill, the durable medical equipment, the home health, the skilled nursing facility bill. So you get more money, but it also the stakes are a lot higher because your cost is higher, especially when you're thinking about Medicare Advantage, right? None of us get healthier as we get older. So how do we really help patients age in place, be healthy as long as it can? I mentioned the PPO ACO model. Similarly, even though the dollars don't flow through us, it is still fee for service and paid by the health plan, where we work with our network, and we have quality goals, patient experience goals, total cost of care goals that we can work with. And then, like an example, maybe I sprained my ankle, right? You don't need to come to me in the emergency department. I'm very good at what I do, but it's very expensive to come to see me to get an x-ray of your ankle. Where instead you could go to an outpatient radiology center. Some physician offices have radiology machines. You're still being, having that x-ray read by a board certified radiologist. It is not a highly complex, but the cost differential of that side of service is huge. And that's part of also what we take a look at. What's the right thing to do for the right patient at the right time in the right place? So I will hand it off to Ed.
Thank you, so at Sutter, we have all the same flavors I just mentioned. So what I will add over there, so for us at Sutter Health, right now about a third of our patients come in a value-based construct that Pam has brilliantly give you all the drill downs that they have. So we're kind of in a mixed reimbursement world over there. So I think part of our challenge that I'll add to that is that it's hard to kind of with one operating model to serve two different payment systems to take care of that patient. So some of the work that I do that we're trying to look at is, do you create different delivery models to support the patients? And I think and that kind of connects to a lot of people in your room over here. How does digital health and solutions apply in our environment where it makes sense for all our patients? Where does it make better sense for value-based patients or otherwise as well? The other thing I would add over there is that part of it that we do have a payer lens about this, recognizing that taking risk in Medicare patients is vastly different than what you have to do for commercial patients. The Medi-Cal population is also very different than the commercial ones. So the needs that we need to meet and what our patients need, it's not a one-size-fits-all. And the more you drill into value-based care, particularly in the delivery side, there's ample opportunity to kind of look at how do we make care more efficient? How do we look at the population and understand how do we segment them, and then looking at ways to bring resources and avenues to improve their health, take out the avoidable costs in the system that matches to where the patients are and also matches up to what the payer arrangement is as well. So it's, in a way, it's very exciting, but also in a way it's also bewildering because we try to have scale things that can scale across different payer types and patient populations. I think those things are far and few in between, but then in the mission, when you take full risk, when your population is so heterogeneous, how do you organize the care? How do you deliver the care that is patient-centric and meets the goals of what value-based care in the contemporary aim needs to? And I think that's where the collaboration and the partnership for you in the room is going to be important. Thank you.
Yeah, and I would add from the health plan perspective, since most of the health plans, I would say most health plans are not in care delivery, they're really the enablers of value-based care. So they are coming back to the cost of the value-based care. What happens is, as a health plan, we create benefit design for the member. So for the patient, we call the member, the patient, the human, that if we can elevate our value-based providers at a lower patient share cost, like the copay is less, on the surface it may feel like, oh, this is cheap, but it is not. In the back end, the health plan is reimbursing the providers at a higher level when they are a higher quality. And so as not just unique to, again, United Healthcare, but as health plans look at themselves in this very turning times, I would say it is much, much more. Previously it was fee-for-service, HMO, let's go. But now it is, the member is asking that retail, that consumer experience in which they care about the value. Hence the One Medicals of the world. They're willing to pay $100-some every year to have that access, that experience. And so from a health plan perspective, when we look at, we think of us as enablers of value-based care, whether it's delivering a shared risk relationship on an HMO side, or a global risk relationship, or an ACO relationship. The more we kind of move in that direction in which we can engage our patient, the human, in the higher quality and lower cost burden, I think we can engage them in a higher quality or more value-based relationship with us.
Do you think that patients understand the plans? Do you think that they feel that they are paying less and they have more options, or do they feel that they have limited options when they choose value-based care? I think there's still a misunderstanding from the
We could ask people in the room here.
Yeah, I'm very curious.
Do you understand your plan?
And often they don't, an employer only offers one or two, so very limited by the employer as well.
Yeah, and I would say that the patients are the left out entity in this tripod of relationship. If you think about it, most of the transaction and almost the decisions are being made between the purchaser and the provider. And then the patient is almost like a standby. And as much as, and I'm a clinician too, and we all try to, and you are a primary care physician, I'm a family physician too, and we all, and as an emergency physician, we all try to engage the patient, because the patient, the healthcare is so confusing for that end user, including all of us. I think we are all patients too. It's really hard to understand the plan design. It's really hard to understand what are they buying into. I think it is creating that fifth grade language, not that everybody needs a fifth grade language, but it is important to bring down to a fifth grade language to understand what is benefits, what is benefit design, how can I best use my coverage to care for my health, and that is very, very important. Yeah.
I want to bring Khan in because you really showed that you follow that patient through the payer, and then the payer, and then the provider, and then another provider. So through value-based care, following their journey, this patient, are you measuring patient experience? Or is patient advocacy going up with value-based care?
It's interesting when we look at the high level and we see organizations that are investing in primary care. They are investing in the experience for the patient. They are investing in population health, upstream, preventing all of that upstream. You see organizations investing in that, and so their performance is reflective of that. And so we're actually able to see, does the patient stay with Dr. X, part of Hill Physicians? Or we're able to see, because we have a very, very deep footprint in California, we see churn and the rate of churn between health plans that are our customers, and we can actually see movement of patients between providers and provider groups. So the ones that are high-performing entities that participate in value-based care have a higher retention rate of their own patient population. That's a big deal.
And this would be the primary care part of the care, right? These are primary care physicians offering more preventative services and being more hands-on.
Yeah, I would say a lot of the care delivery is with primary care. So yes, they are the center of all of this, but organizations like Sutter or Hill that invest in value-based care at a centralized perspective, they're adding services and care coordination and population health campaigns and programs that is a wraparound to primary care that also support the patient. And so, like, if you think about value-based care, it's that whole, from the care delivered at point of care to then the wraparound services as well.
You know, I wasn't going to ask this, but I did see a survey that showed where value-based care is utilized. This is a McKinsey report, and it's primarily primary care. But Archana and I did a lot with behavioral and mental health. You were at Livongo, you said, so that's behavioral mental health. I would have thought that value-based care, behavioral mental health companies would use value-based care models, but they're sort of on low adoption rate. Does anybody know why?
I would say value-based care started with primary care because all of care kind of comes physical, mental, everything, this kind of front door. But we are seeing value-based come into bundle solutions for orthopedics, mental health, and other areas. Bundling is, or oncology. Bundles are starting to happen and actually have been happening. That is also a version of value-based care in which you bundle the whole care of knee replacement, for example, under one capitated rate, and then every care is taken care of underneath it. So those are other versions of value-based care. You had
a comment on behavioral health. I think one of the biggest challenges around behavioral health and maybe less adoption is years ago it was carved out to separate health plans. So you had the behavioral health benefits, the behavioral health plans, and I'm going to be over here on my island doing my thing, and you know the medical side of the house is over here doing their thing, different health plans, not a lot of collaboration in between. We know behavioral health is such a key driver for health outcomes, right? Medication adherence, the insight to be able to understand your disease burden. And so, I mean, I think that is an area where I would really like to see better integration moving forward. And we're moving in that direction with, some of these collaborative care models. Yeah. But I do think that it's a whole person care, right? And not trying to separate that out into two different areas is an area of opportunity for all of us.
And that's something that we have held behavioral health panels, and one of the biggest mistake I think we have done is to split primary care into physical health and mental health. Health is health. For an end user, health is health, care is care, primary care, urgent care, whatever it is care. And they want it the way they need, they want to consume it. By the way, that's where our patients are. But the collaborative care model is one of a classic example in which we combine hands and we treat our patients with higher quality outcomes when we sit right next to primary care. When we put behavioral health right combined with primary care, that's when magic happens. For example, diabetes doesn't exist by itself. It has some level of depression with it. You treat depression, diabetes gets better. You treat diabetes, depression gets better. There is no separating the physical and mental health. We have done a disservice, and hence we're seeing immense crises in mental health space.
Yeah, I think the thing I would add, I echo all those points, is if you're looking for an area for disruption, I do think how we approach mental health will be a great area to go into. There's a huge disease burden out there. It's under-captured. The newer generation is more receptive of that. But the models we take care of patients are woefully inadequate. There are not going to be enough providers trained in this area to serve this. It has to be done in a different way, and I do feel this is an area where, particularly in value-based care construct, because at the other point why mental kind of psychiatrists and behaviorists kind of stay where they are is just that they have no incentive kind of move into a value-based construct. because they have a shortage and they just stuck with the way how they're used to. So this will be an area that we'll look vastly into it, and particularly looking at solutions that can help with these outcomes that supplement the traditional human interaction phase of that, because I think if we continue on the current trajectory, it will never meet our needs in this space, and I think this will be a very exciting area, and I'll look to kind of hear some of the efforts that you have in this space. Thank you.
You made me think of, I wasn't going to go down this rabbit hole of psychiatrists and mental health providers, but I was thinking about a psychiatrist and somebody seeing a therapist and the therapist thinking, I'm going to have you for 3 years. This is great, at least. But anyway, I wanted to talk about measurements. How do we measure this stuff? And how do we measure a digital health vendor's contribution? Everybody here is talking about sharing risks. Well, who wants to share in the risk? That's scary, especially if you're a startup. But first, let's start with the BBC models, the value-based care models, the ones that Pam listed off. And Khan, again, you're the one, you sort of have this God's eye view of everything that's happening. What are the models you found to be resulting in the best care and the lowest cost?
Yeah, I have a couple notes here, so I'm sorry if I'm going to be reading off of it, but I think the most effective models have multi-dimension components that are critical. It's hard to tease out, like, can you do a model with just that, just incentives? Let's just align incentives, right? Well, that's a start, but you have to have a way to measure incentives and report out on the results of incentives and make it actionable for whoever it is that can earn the incentive to know. So for example, if a health plan is contracting with a provider group and there is a component where it's earned for outcomes and performance, well, do I know what measures you're going to measure me against?